Good morning, everyone. Welcome to Pediatric Grand Rounds. This is Dr. Parmeshwar. We appreciate your time and joining us this early in the morning. So, a topic of global importance, racism. While we may all have been aware of the issues in all settings, criminal justice system, the workplace, the school system, it is no more of no more devastating importance than its impact on our most vulnerable population, our children. Today, we're thrilled to have Dr. Adiaha Spinks-Franklin, a developmental behavioral pediatrician in the Mayer Center for Developmental Pediatrics at Texas Children, and associate professor of pediatrics at Baylor College of Medicine. Dr. Spinks-Franklin is a graduate of Meharry Medical College. She completed her pediatric training at Children's Hospital of Michigan and went on to Children's Hospital of Boston at Harvard to complete her fellowship in developmental behavioral pediatrics. She also completed the Dyson Advocacy Fellowship at that time and managed to throw in a master's in public health at that time as well. In addition to her clinical duties, she heads up at multiple international projects in the Caribbean, Africa, Pakistan, and South America. She is heavily involved in social justice medicine and leads a team that conducts workshops and seminars nationally to promote anti-racism in the healthcare system. Please join me in welcoming Dr. Adiaha Spinks-Franklin.
Good morning. I first want to thank Dr. Parmeshwaran for inviting me. She was my senior resident at the Children's Hospital of Michigan when I was an intern. And I looked up to her so much. She was just calm and cool and collected at all times when we interns were scared out of our minds. So I really thank her for this presentation, for this opportunity. So let's get started. I have no financial disclosures, but I do disclose that I'm an ardent anti-racist. I identify as a Black American, cisgender, straight woman, and I prefer she, her pronouns. And I experience racism. And because of my experiences with racism, they have informed my worldview as well as the clinical and research work that I do. First, I want to thank everyone in advance for giving us permission today to talk about a topic that nobody likes to talk about in mixed company. And I thank you in advance for bringing your openness, your flexibility, and your compassion to today's session. And I thank you in advance for allowing yourself to grow in this experience by becoming comfortable with being uncomfortable. It is through being uncomfortable and our discomfort that we have an opportunity to grow. It's like having growing pains. So now I'm going to give you a warning. If you begin to have any of these feelings during the talk, if you're feeling singled out, attacked, silenced, ashamed, guilty, accused, insulted, judged, angry, scared, or outraged, you might be tempted to do any of these behaviors. You might feel like you're becoming defensive. You may want to cry. You might want to leave the room or put me on mute. You might want to become withdrawn or argue with the computer. You might want to deny the existence of what I'm discussing. You want to focus on your intentions versus the impact of your behaviors. You might want to seek absolution or even avoid the discussion altogether by checking emails and doing your notes in Epic or checking your Facebook page. Instead of having those behaviors, I invite you to breathe deeply and try one of these. Say something like, I'm really nervous or scared or uncomfortable saying this, but this is what I'm thinking. From my experience and perspective as how you identify racially, describe your experience. I'm afraid I might offend someone, but please let me know if I do, but this is what I'm thinking. I'm not sure if this makes any sense, and say what you're thinking. These are ideas for countering the defensiveness of what has become white fragility. And these come from a reader's guide from the book White Fragility by Robin DiAngelo. If you have not read the book or read her article on the topic, on the construct of white fragility, I will encourage you to do so. So let's get into today's talk. First, we're going to review some racial literacy concepts. Then we're going to define racism in all of its forms. We're going to explain how racism is an adverse childhood experience and describe ways of addressing racism. All right, let's get into racial literacy. So race is a social construct. It is not at all biological, although in preclinical medical school curricula, it is often taught as a biological concept and as a risk factor for disease. Race is not a risk factor for disease. Racism is a risk factor for disease. So the concept of race was actually created in the United States during the late 1600s after a major slave rebellion that was referred to as Bacon's Rebellion in 1676. And in that instance, European landowners and lawmakers in the colonies, especially in Virginia, decided after this major rebellion of both Black and white slaves, the European slaves and the African slaves, that they wanted to use the most notable physical characteristic to create a caste system in the United States. So they chose physical skin color and very obvious physical features, which are actually normal human variations. And these are normal human variations that are not divided by specific groups or geography, but they're found all over the world. And those European landowners and lawmakers in the United States could have used height as a way of determining a hierarchy, the shape of our earlobes, whether or not they are attached, but instead they chose skin color. So there's no biological evidence or scientific evidence for race. It's socially real, but biologically not real. And people who are considered white today were not considered white 100 years ago. In fact, Jews, Italians, Russians, the Irish, the Polish 100 years ago were considered to be colored. And over time, their descendants of those early immigrants from the late 1800s, early 1900s were eventually enveloped into the category of whiteness. So as James Baldwin said, white is not a race, it's a metaphor for power. So look at these census categories. If you look at the US Census over the centuries, it is a fascinating document to show how the concept of race has evolved in the United States. So in the 1790s, as you see, people who were considered a race were free white males over 16, free white males under 16, free white females of all ages, all other free people, whoever those were, and then slaves. Slave was considered a race. Then in the 2010 census, we were given all of these racial categories, but then one ethnicity category, which is really arbitrary and random. It doesn't make sense why Hispanic would be an ethnicity, but then white would be a race. That there's no logical evidence for making these arbitrary categories. Racial literacy is a way for us to be able to communicate effectively and to understand concepts of race. So it includes racial vocabulary and concepts and language that we use that is beyond the kindergarten and preschool idea of racism as someone being mean to someone else, as if being nice can solve this problem. Racism is not being mean to people. It is a system of racial oppression based upon white superiority and the inferiority of non-white people. So this construct of racial literacy, which was developed by Francis Twine who's a Black Briton, he says that it is this way of identifying and recognizing racism in all of its forms, developing strategies for countering and coping racism, and for teaching your children how to manage that system as well. So these are the main components of racial literacy that Dr. Twine describes in his book. And we're going to focus on number 5, which is the grammar and vocabulary. So if you can take a screenshot, you guys actually are free to take a screenshot of any screen you see. If you want to read the references, if you want to look some things up, I invite you to do so. So these are some of the most common words that we discuss in issues of race and racism. Prejudice is when you prejudge something without having all of the information that you need. And usually it's a very negative attitude. And in the United States, when we say someone is prejudiced, it's usually about race. But you could be prejudiced against religion. You could be prejudiced against ideologies, political groups, any kind of thing you could be prejudiced against. A stereotype is just an oversimplification of the characteristics of the group. And it is not representative of all the people. like saying that all Asians are good at math. Like that is a stereotype based on the myth of the model minority. Bigotry is when you treat a member of another group, it could be a racial group or a religious group, with hatred and intolerance. So it is the way you actually treat them. And bias is these prejudicial attitudes either for or against something, a person, a group. And your biases can be explicit, meaning that you are fully aware of your biases. Like my favorite ice cream flavor is butter pecan. Like that is an explicit bias. But your implicit biases are subconscious and unaware. And there's been a lot of evidence in the literature on the implicit racial bias of physicians and other healthcare providers. Once you know what your implicit bias is, it is no longer implicit. It becomes explicit. And now you're required to do something about it. Discrimination is when you act on your prejudicial and your bigoted attitudes to actually deny someone social participation or human rights. That is discrimination. Now, a microaggression is a term that some people aren't familiar with. And these are the little everyday slights that are really offensive, that occur by a member of a dominant group against a member of an oppressed group. So there can be derogatory messages. Like I had a colleague to tell me just 2 years ago, a colleague I work with, after I did an interview on the local television news, that I speak so well. That was a microaggression. That is the most ultimate insult that you can give a person of color. I mean, formal English was my first language. Then I learned American Sign Language, then Spanish, and then I learned Ebonics last as a teenager. So to tell me that I speak so well is really an insult. So the only time we should ever tell somebody that they speak so well is if you're the speech therapist and you were giving speech therapy to a person who stutters or have some sort of speech impediment. And in that session, you say, my goodness, Adiaha, you are speaking so well. That will be appropriate. Outside of that setting, do not tell somebody they speak so well, please. Now, intersectionality. That is another term that a lot of people are unfamiliar with. And this is where you have overlapping of social categories. So, for example, a Latina woman is a member of a racial minority group, and she's a woman. And if she experiences discrimination for being a female and being Latina, then that's called gendered racism. It's the overlapping of sexism and racism. That is a form of intersectionality. A racist is a member of a politically, economically, and social dominant group who either passively or actively promotes the system of racial oppression. No one ever admits to being a racist. Governor Wilder in Alabama never admitted to being a racist until he was shot. So most people who have racist views never publicly admit that they have racist views. Now, an anti-racist is the opposite. That is a person who actively works to interrupt the system of white supremacy, racial oppression, and systemic racism. And an anti-racist can be anybody of any racial group in the United States when you actively work to dismantle the system and uphold racial justice. And white fragility is a construct that was coined by sociologist Robin DiAngelo. And it is the reactions that whites face when they have to deal with issues of race and racism. So even the slightest or minimum mention of race or racism, it can become really intolerable, and it can trigger a range of defensive moves and emotions from whites. That's called white fragility. All right, so now what is racism? Racism is a system of white racial superiority and the oppression of non-white racial groups to maintain white racial superiority. Racism includes two main factors. You've got racial prejudice. So you have very discriminatory and derogatory attitudes based on these assumptions of skin color or race. And then you've got social power, this historical, social, political, and economic privilege that is bestowed upon some groups and denied to others. So you put together racial prejudice and social power, and you've got this system of racism. That's sort of a little simplified way of looking at it. Now, Dr. Kamara P. Jones, who is a physician scientist who is currently at Morehouse College and spent 15 years at the Centers for Disease Control and Prevention, Dr. Jones published a really important paper in the year 2000, and I encourage you to jot down the reference at the bottom and read this paper. She says that racism comes at three different levels. There's institutional racism, there's interpersonal racism, and then there's internalized racism. And we're going to talk about each of these. Institutional racism is also called structural racism or systemic racism. And this is a form of racism that is actually codified into our institutions, such as our customs, our laws, our policies, our practices, our traditions, that actually discriminate against specific racial groups. And institutional racism can be normative, sometimes it's legalized, and it's often manifested in as inherited disadvantage. So there are just some groups who have just born into a system of disadvantage, and there are groups that are born into a system of advantage. That is institutional racism. So they could be through laws or acts of omission and commission, and there, in essence, is a differential access to goods, services, and opportunities of society by race. And then Dr. Jones goes on to explain that there are material conditions and there's access to power. So there's a differential access to material conditions like equal education, clean and fair housing, employment, healthcare, environment, a clean environment, or access to power like access to information, resources, and even political voice. Now, interpersonal racism is also called personally mediated racism. Now, this is a form of racism that most people think about as racist. Like if someone calls you a racial slur or denies you service in a restaurant. So this is defined as a prejudice or discriminatory action that is experienced between members of a dominant racial group. In the United States, that would be white people, toward members of stigmatized racial minorities. Now, the act of interpersonal racism can be intentional or unintentional. It can also be acts of commission or omission. An act of commission would be doing something to actively mistreat a person of color, such as an act of microaggression, saying that that person, asking them where they're from, or it could be an act of omission where you just deliberately don't even invite this colleague out to dinner when everyone else is going out to dinner or to lunch together, or you actively not hire certain folks into positions of power. You don't even consider them when you're going through applications. So implicit bias really plays a major role in interpersonal racism because it's your negative implicit racial bias that fuels this lack of respect, suspicious behaviors, devaluing people, scapegoating, and dehumanizing people. And then the act of interpersonal racism can be either a micro or a macro aggression. Once you've recognized that you've committed an act of interpersonal racism, it is really important to focus on the impact of your actions and not your intentions. If we focus on our intent, that we did not intend to be racist, we did not intend to offend someone, or tend to engage in bigotry towards someone, that actually negates the feeling that that person and the experience that they had, the impact of our actions on them. So the research says we need to be focusing on the impact of our actions and not the intention behind them. So let's talk about implicit bias. Implicit bias is our unconscious prejudice. It's either in favor of or against something or a person. It's at a subconscious level, and it often runs contrary to our conscious beliefs and values. And it's triggered through these rapid automatic mental associations that we make in our brains that tell us what is familiar, what's unfamiliar, what is safe and what is unsafe. That's what triggers our implicit biases. So I consider it to be the engine that runs acts of interpersonal racism. There's a test for implicit bias that was developed at Harvard, and it is called the implicit association test. And millions of people have taken the implicit association test. There are tests that look at racial bias, gender bias, weight bias, disability bias, etc. The vast majority of people who have taken the implicit attitude test actually demonstrate a pro-white anti-black bias and a pro-light skin anti-dark skin bias. And the healthcare providers mirror the exact same attitudes as the general public. Physicians, nurses, social workers, occupational therapists, genetic counselors, you name them, have been found to have overwhelmingly pro-white, anti-black implicit bias. And this affects the way we administer healthcare and care for our patients. The last form of racism is internalized racism, and that is the third level. That's where you actually accept that whites are superior and non-whites are inferior. So for those who are members of a racially stigmatized group, you actually drink that Kool-Aid and you actually believe that non-white groups are inferior and white groups are superior. And for whites is also believing that whites are superior and non-whites are inferior. And there is incredible evidence, lots of racism, as you can see, lots of evidence from all of the studies I have at the bottom of the screen, that internalized racism is very harmful, and it is associated with depression and other serious psychological problems in African Americans, Latinx Americans, and Asian Americans. It's also been found in American Indians and Arab Americans. And internalized racism has been correlated with suicidality in white Americans. We'll get into that in a little while. I want to quickly talk about colorblind racism. This is a form of racism, not a level of racism. Colorblind racism, cultural racism, these are other forms of racism. And colorblind racism is when you say things like, I don't see color. When people say that to me, I say, then you don't see sex. You can't tell that I'm a woman. And you need to go to the eye doctor and you need to get your vision checked and get that cranial nerve too and your occipital lobe worked out, because something ain't right if you can't tell that I'm a Black woman sitting here talking to you. So racial colorblindness is now the most common and lethal form of racism in the United States. It is where people believe that race doesn't matter anymore. Racial group membership should never be taken into account for strategies for including for diversity and inclusion relationships in organizations. They deny the struggles of people of color and the ongoing system of racial oppression in America. And colorblind people were those who said when President Obama was elected that we lived in a post-racial America. That phrase always surprised me because I had no idea what they were talking about. Because as a Black person, it was abundantly clear that racism was still a problem in America. So now let's talk about these are the various forms of racial colorblindness and how it can actually go through our institutions. I encourage you to either read the article that delineates them, take a screenshot of this particular slide. So we can have colorblindness in our interpersonal interactions with folks, in our educational system, where we actually whitewash the curriculum, and how we choose to what holidays are celebrated in schools and how the experiences of people of color are portrayed. There's organizational colorblindness, where organizations just normalize all employees across the board, do not take any kind of racial differences into account, and they talk about the organizational identity rather than the individual needs of their employees. Then, of course, there's legal colorblindness, which is also dangerous, where the idea is that judges have zero bias and they don't take any race-based considerations. Well, there's an entire construct of legal research called critical race theory that was established in the 1970s onward by Black law students and Latino law students that says, no, we must think of the law in the context of racial history in the United States. Then there's societal colorblindness, where they perpetrates, which can perpetuate existing racial inequalities. Where just as a society, we act like racism isn't the problem. How is racism an ACE? Let's get into that. So as physicians and healthcare providers, most of us are very familiar with the Adverse Childhood Experience Study that was performed in 1998 by the CDC and Kaiser Permanente in in San Diego. And they found that 2/3 of their respondents to their questionnaire had experienced abuse, neglect, and household dysfunction, right? And then the Centers for Disease Control began to measure ACEs around the country using the behavior risk factor surveillance system, but they only measure abuse and household dysfunction. When I went to the CDC last summer to talk to them about racism as a risk factor for disease, I encouraged them to include neglect questions again in the behavior risk surveillance system, because neglect is a much more common form of child maltreatment than abuse. But what's really important is the Philadelphia Urban ACE study that was performed in 2013. The Philly ACE study not only included the original 3 categories of ACEs from the CDC Kaiser study, they added additional adverse childhood experiences, with racial discrimination being one of these experiences. And this is what they found. When you compare the three studies, the demographics are quite different, in the sense that with the Kaiser study and the CDC study, those were overwhelmingly white. And in the Philadelphia study, because of the population of Philadelphia, you saw a more even distribution between Black and white, but smaller numbers of Hispanics and Asians. The educational distribution was also different, and you had about 17, almost 1,800 that participated in the Philly study. And when you compare the outcomes, you see that 34.5% of the folks that participated in the Philadelphia A study reported that they had experienced racial discrimination. Now, let's talk about redlining as a form of institutional racism. Redlining was something that I consider the root of all racist evil in the United States. This was the redlining map for Richmond, Virginia in the late 1930s. And this was a part of the New Deal from President Franklin Delano Roosevelt. The Homeowners Loan Corp decided to grade neighborhoods in different cities into 4 different categories. With the red neighborhoods that were considered in the red category as hazardous were neighborhoods with very large racial minority residents and immigrant populations. And what cities did was systematically disengage financially from those neighborhoods. So banks refused to give out loans or offer credit to people who lived in those communities. There was limited community development in those neighborhoods that were red zone. And even though redlining was outlawed in the 1960s, it still goes on today. It is still responsible for our ongoing racial housing segregation, which is associated with educational, school segregation, poor health outcomes, and poor economic outcomes. So when you look at redlining as is a form of institutional racism, lots of studies have found that if a person lives in the red line zone, I'm not familiar with Richmond, but those of you who are familiar with Richmond, Virginia, if you look at those red zones, you are familiar with what those neighborhoods are and the racial and ethnic composition of those neighborhoods. So in red line areas, we found that neighborhood and school racial segregation are very high, and they have inadequate school funding. There's less access to credit, and these people are denied home mortgages and business loans. So as a result, there's less home ownership and less business ownership. There's also kids who live in the redlining zones have been found to have elevated serum lead levels, and we know what lead does to the developing brain. There's concentrated poverty in these areas. There's poor mental health and physical health for Asians, Blacks, and Latino Americans who live in red line zones. There's less access to even retail stores, quality grocery stores, and there's also an increased risk of preterm birth, all from people who live in red line communities. So let's talk about how racism affects prenatal outcomes. So in the United States, the most recent CDC data we have is from 2016. We know that infant mortality among Black babies is very high in the United States. And at one point, it actually matched the infant mortality of babies that were being born in Bangladesh. So infant mortality for Black babies is more than twice as high as for white babies. Black babies are born at low birth weight at almost twice the rate of white babies. They're born at 14% prematurely compared to 9% for white babies. And maternal mortality for Black women is more than twice that, almost 3 times that of white women. And so why is that? Why in the world are Black women in the United States and Black babies in the United States faring so poorly compared to white women in the United States? At first, they thought maybe there's something genetic. You know, we think these Black people might be genetic inferior. And then science proved them wrong. So this is what some researchers, very clever researchers, decided to do, was to compare the pregnancy, birth, and postnatal experiences of African-born women in the United States to U.S.-born Black women to U.S.-born white women. And guess what they found? African-born Black women who lived in the United States had babies that were heavier, healthier babies, full-term babies, just like U.S.-born white women. So that dispelled this myth of some genetic predisposition to poor pregnancy and outcomes. When they surveyed these women, all the women in the studies, what they found was the accumulative experience across the life course of racial discrimination is what was most closely and strongly associated with having a preterm baby. They also found markers of stress in the immune systems of Black American women that were significantly higher than white American women. And specifically, they found the Epstein-Barr virus capsular antigen immunoglobulin IgG. So when you looked at the EBV capsular antigen IgG, they found that those levels were much higher in Black women as a Black U.S. born Black women compared to U.S. born white women. And they were highest in Black American women who reported the highest levels of racial discrimination. And that is a sign of poor cellular immunity. So let me break this down for you. You got a U.S. born white woman. You have an African born Black woman in the United States. Their babies are going to be very similar, full term, happy, fat, and healthy. You have a U.S. born Black woman who grew up in the United States. She's much more likely to deliver a low birth weight, premature baby and have complications throughout her labor and delivery. And she is going to be found to have this increased titer of the virus capsule antigen IgG. Now, when that African-born Black woman gives birth in the United States, her baby, the little girl, is going to be born in the United States and grow up under this system of institutional racism and white supremacy. And when her little girl grows up, guess what? The U.S.-born daughter of the African-born woman will also have elevated VCA IgG, and she will be at risk of having a preterm low birth weight baby. There's something about growing up in a racist society that is destroying our health. So let's go through some of the childhood experiences with racism and their outcomes. On this slide, I summarize educational outcomes, physical health outcomes, and mental health outcomes. This is merely a summary. There's a whole lot of information out there. If you can Google and PubMed and learn all about COVID, you can Google and PubMed and learn all about racism too and the effect on health. And I encourage you and invite you to do so. So let's talk about how racism affects kids. In the educational system, we've got very strong institutional racism, and there are many instances of interpersonal racism as well between teachers and students. Statistics from the United States Department of Education show that of public school systems, 85% of teachers are white females, but more than 65% of students in public schools are actually children of color. And that is Black, Latino, Arab American, Asian American, American Indian. And this is what they found. Black, Latino, and American Indian boys are punished much more frequently and more harshly than white boys for the exact same infraction. Black and Latinx students are much more likely to be put into classes of disadvantage and much less likely to be put into advanced classes like advanced placement courses, pre-AP courses, gifted and talented. They found that Black and Latino students, when they go to schools that are majority Black and Latino, they found that the curriculum is much less challenging and the teachers are much less trained, poorly trained teachers. They also found that Black girls are punished at 6 times the rate of white girls for the exact same infraction in schools. Asian American students who internalize racism and the belief in the myth of the model minority, that would be the form of internalized racism for Asian American students. And that's both East Asian, Southeast Asian, and South Asian American students. They actually report higher rates of anxiety and depression compared to Asian American students who don't internalize and believe the myth of the model minority. And they're actually less likely to engage in help-seeking behavior. Let's talk about that for a second. This research is really compelling because they looked at Asian Americans who were children, adolescents, college students, and young adult professionals. And they found across the board that if they believed in the myth of the model minority, they were much less likely to get help when they needed it. So that meant in school, in primary and secondary school, they were less likely to get the kinds of educational supports that they needed if they were struggling in school because the myth says that they're good in school. If they were in college, they were much less likely to reach out to professors for assistance. And in jobs, they were much less likely to reach out if they needed support or assistance, which also contributed to the bamboo ceiling because they were not actively seeking for these additional opportunities. So there's definitely consequences for everybody. Physical health is very important as well for children. There have been a bunch of studies showing that teenagers who report having experienced racism, whether from their teachers or from members of the community, they reported lower satisfaction with their healthcare quality if they perceived that their healthcare providers were racist. And they also were found those who perceived having racial experiences had poor metabolic control, poor dietary adherence, poor insulin resistance. So think about this. Think about Black and Latino students particularly, who have higher rates of obesity than other kids in the United States. And you have an obesity program at your hospital. And we talk about how they are just so non-compliant and they don't rely on their diets and they don't stick to the plan. Maybe these kids have been experiencing racism at school and in their communities, and maybe even through the healthcare system, but no one's actually asked or drilled down into the underlying reasons why they may not be adhering to the recommendations in these obesity programs. Now, there was a mental health survey, the National Survey of Children's Health, and in 2011 and 12, they actually included one question about experiencing racial discrimination. And when they controlled for all of the socio-demographic features, they found that there were much higher rates of depression and anxiety among Blacks, Latinx, American Indian, and Asian American adolescents that reported having experienced racism. So let's talk about vicarious racism. I don't know if you've heard of this term, but Nia Hurd-Garris is an amazing researcher from Robert Wood Johnson. She did a systematic review back in 2018 of this construct of vicarious racism. This is like secondhand racism. It's where children observe racism experienced by their parents or racism in the community or in the media. And what her research found is that when children experience or see racist experiences that their parents have had, that it affects them physically, mentally, and emotionally, and it also affects their development overall. In her systematic review, she also talked about prenatal maternal experiences with racism and found that this is what we talked about again. The baby is much more likely to be born preterm. The baby is likely to have cortisol reactivity postnatally and to have a lower birth weight. Isn't that something? So even though the fetus is not aware of the mother's experiences with racism, the fetus becomes a victim of the mother's experiences with racism because her cortisol levels cross the placenta and affect the baby's growth and development. So it's very interesting that when kids witness experiences or even hear about experiences that their parents have had, that it can lead to all of these physical and mental health outcomes in the future. What we don't have data about is if watching racist events in the news, like watching police brutality in the news, watching the video of Amy Cooper calling the police on the Black man in Central Park, right? If you watch that over and over again, what does that do to the outcomes of kids? We know that there are some depressive symptoms, but we haven't figured out the mediators and moderators of that effect for vicarious racism. Now let's talk about adult experiences with racism. So there have been numerous studies that look at outcomes for Black folks and Latinos, Asian Americans, American Indians, Arab Americans. And what they have found is highly educated Black people actually fare worse in the United States than white people who have the lowest levels of education across multiple health outcomes. Isn't that amazing? And adults who report experiencing discrimination, racial discrimination, such as whether it's institutional or interpersonal racism, they have poor cardiovascular health, poor metabolic control, worse cancer survival rates, and a shorter life expectancy. Isn't that something? So even with equivalent levels of care, there's still a concern that racial and ethnic minorities experience lower quality health care than whites. And that comes from the Institute of Medicine report. So talk about some biological mechanisms. I actually drew this, and then I found a schematic that was so much better than my drawing. But I had already submitted my slides, so I didn't change it. This is what has been found in the literature that has been so fascinating. When a person is confronted with racial stress, the racial stress becomes triggered in the regions of the brain that are there for recognizing threat and danger and violence. And what that does is it sets off the hypothalamic pituitary adrenal axis and the sympathetic nervous system. It also activates the sympathomedullary adrenal system as well. And what we end up with was high levels of stress hormones, including cortisol and other glucocorticoids. And over time, with repeated stress, you end up with a very elevated allostatic level. In fact, studies have found that when a person experiences racial discrimination, people say, gosh, that really hurt me. And it is because the regions of the brain that are responsible, those neural pathways for somatic and physical pain, are also triggered for emotional pain when we experience racial discrimination. So as a result, with this increased stress hormone load, it leads to an inflammatory response in the body. We end up with increased waist circumference and obesity, high blood pressure, poor memory and concentration, weakened immune systems, diabetes. All of that is associated with experiences of racial discrimination. There's also an incredibly interesting study by Dr. Che and colleagues that studied African-American men who had experienced interpersonal racism and internalized racism. Interpersonal racism being the microaggressions and discrimination experienced, and the internalized racism, they gave them measures to look at whether they had pro-Black internalized ideation or an anti-Black ideation. You know what they found? They found that the Black men who had experienced high levels of interpersonal racism had shorter telomere lengths of their DNA in their white blood cells. And they found that Black men who had internalized anti-Black racism, where they looked down on their own people and saw whites as superior, they had very poor short telomere lengths as well. And Black men who had both experienced interpersonal racism and had internalized racism together had the shortest telomere lengths. And shortening your telomeres is a sign for chronic disease, aging, and early mortality. So this is where racism is embedded in the DNA, these epigenetic changes that happen because of chronic life course stress of racism. So now what does racism do to white people? So white people are not exempt from the experiences of racism in the United States. It has been very interesting studies that have looked at the internalization of the construct of whiteness, this idea that white is normative and is that white is the baseline, white is the standard, and that white should have access to all that is good in the United States. When you internalize that belief system, this is what they found among teenagers and adults. There's 2 to 3 times the rate of suicide in whites compared to non-whites who internalize racist views. Seniors in high school who are white that internalize racist views are actually twice as likely to binge drink compared to Blacks. Whites who internalize racist views have less flourishing. Flourishing is a body, a construct that refers to really good mental health outcomes and like feeling good. They have lower levels of flourishing compared to Blacks and other racial groups, non-white groups. There's also higher levels of mortality among whites who report prejudicial attitudes when they live in a community has low prejudicial attitudes. Isn't that interesting? So if you're a really racist white person and you live in a low racist community with very little racism, you're going to die faster than your neighbors. And whites in the United States have poor health outcomes and lower life expectancy than white folks in Europe and people of color in other nations. And that has also been correlated with having these internalized beliefs in white superiority. And one of the theories behind this is that whites who have the belief in white superiority and the inferiority of non-white people have these expectations that whatever they apply for, whatever they want should be theirs. And when that need or that expectation is unmet, it contributes to poor physical and mental health outcomes. So let's talk about physician negative implicit bias and how implicit bias contributes to poor health outcomes. This is a implicit bias, remember, fuels our interpersonal racist interactions. So with implicit bias, healthcare providers, as we know, have a much higher pro-white, anti-black, or pro-light skin, anti-dark skin implicit bias. And they found that it actually makes a difference in how they provide health care to their white patients compared to patients of color. And in numerous studies, and I'll only put a few here at the bottom of the screen, they've shown poor communication effectiveness. They found that providers who have a pro-white, anti-black bias were, when they had a patient of color, they actually dominated the conversation more, and they asked the patient fewer questions. And their body language and their posture was much more hostile when in a room, an exam room, with a patient of color as opposed to a white patient. Isn't that interesting? They also found that physicians with pro-white, anti-black bias provided inappropriate treatment recommendations for their patients of color. So they were much less likely to recommend appropriate test measures, referrals, antibiotics, etc. And in the emergency department, there have been numerous studies looking at how implicit bias of physicians contribute to poor pain management in the emergency department. And one of the reasons for that is a study that we're going to talk about in a second that actually looks at these false beliefs among medical students and residents that Black people can just tolerate more pain than white people. They're less sensitive to pain. That is a false belief. That is a lie. And also, patients of color who experience who have had a provider with pro-white, anti-black bias actually report that provider as having poor patient care skills, bedside manner, and they report less satisfaction with their health care. So let's talk about this trainee bias. So, we talk about the new generation. We hope the new generation, every generation hopes that the next generation going to do a better job than they did, because we have all miserably failed in dismantling this 500-year-old system of racial oppression in this nation. So there was a very interesting study with 400 plus medical students and residents. And they were given an implicit association test and some other measures. And half of these students reported having at least one false belief about biological differences between Black and white people. It was amazing. So these are medical students and residents who've been through medical school, who have taken pathophysiology, who know medicine, yet they believe that Black people were less sensitive to pain than white people. Black people had thicker skin, stronger bones. The list was really long in these false beliefs. And the sad thing was that their false beliefs of the medical students and the residents were exactly the same as people in the public who took the same questionnaire, who had never been to medical school in their lives. So what does that tell you? That medical school did not help them unlearn their racist beliefs. And what they found in this study is that the medical school students and the residents who had these false beliefs, well, they were presented with a case scenario of a patient with pain, and that patient was Black versus white, they would consistently rate the Black patient's pain at a lower level than they rated the white patient's pain. And they made less appropriate treatment recommendations for Black patients compared to white patients because of this false belief that they have. Talk about addressing racism in clinical practice. So what exactly is an anti-racist? So I'm sure you guys have heard of this term now. It's been used a lot in the media, which really makes me happy because this was not a term that was commonly used in the media previously. So an anti-racist is a person who identifies racism and they actively work to oppose and dismantle the system of white supremacy and racial injustice in the United States. An anti-racist doesn't just passively uphold the system of white supremacy and racial injustice, they actively fight against it. Being an anti-racist is the opposite of being a non-racist or not a racist. A non-racist or not a racist is just passively there. They believe that if they didn't use a racial slur, or they have that one Black friend, that they must not be a racist, or they're married to a person of color, they must not be a racist. No, an anti-racist, you're not born an anti-racist. If you grew up in the system of the United States, the racist system and society of the United States, that means we have all internalized racist views of white superiority and the inferiority of non-white people. So in order to become an anti-racist, you have to actually work to overcome and to conquer the internalized racism that all of us have digested growing up in this country. So you have to work on your own implicit and explicit biases, and you constantly work to overcome them. And you align yourself with oppressed people, and you work to interrupt these systems of oppression. That's an anti-racist. So as you know, the American Academy of Pediatrics put out their a policy statement in 2019 that was written by Maria Trent and her colleagues, which was very good step for the AAP to actually talk about racism and the effect of racism on child and adolescent health. So we're going to just review what's in this policy statement. If you haven't read it, please read it. And if you have read it, reread it and start incorporating these recommendations into your clinical practice, into your section guidelines, into your hospital and institutional policies. So the policy statement says that we know that racism is a social determinant of health. And my group, Race Card, is working to get racism also to be officially considered an adverse childhood experience. Racism has a profound impact on the health of children, adolescents, young adults, and their families. Healthcare providers are in a unique position to improve health outcomes by disrupting racism in healthcare. This is a part of the universe we can control, right? All right, so let's talk about it. How do we eliminate racism in healthcare? So these are 4 of their big overarching recommendations. One is optimizing clinical practice. Another is optimizing workforce development and professional education. Another is optimizing systems through community engagement, advocacy, and policy, public policy. And the last is optimizing research. Let's talk about clinical practice. If you want to address racism in clinical practice, one of the things you got to do is become comfortable being uncomfortable, y'all. So you can actually discuss with your patients experiences of racism that they have in a culturally respectful way. So let me tell you how I do it. So I'm a developmental behavioral pediatrician, right? And we take really long social histories because understanding the biopsychosocial experiences of our patients gives us context for figuring out their developmental disabilities and their behavior disorders. So because a child is not growing up in a bubble, they're growing up in an environment. So when I take the social history, I ask about stressors, right? We all ask about stressors. This is how I ask. Has your family experienced any recent major stressors, such as a change of job or loss of job, financial problems, marital discord, a major illness or death in the family, having to move? I live in Houston, so I have to ask about natural disasters like hurricanes and floods because it happens all the time. And I'll also ask, and has your family experienced discrimination, racism, or problems with immigration? That's how I ask the question. It's woven into my social history, and I've made it a habit. So I ask it to everybody, people that I think are white or people who identify as white, and everybody else. I want to know how your stressors have affected your life. If families have experienced racial discrimination or any kind of discrimination, they'll share it with me and we'll talk about it. And we'll figure out, okay, well, do you think your child's behavior problems could be, or the way the teacher describes your child could be because of your child's skin color? Do you think that might be an issue? Or do you think your neighborhood and how your neighbors treat you, do you think it's because you guys are Asian American and the rest of your neighborhood is white? Like, what do you think is going on? So we actually talk about those things. If they're legal matters, then I refer them to the Medical Legal Partnership or the volunteer lawyers or one of those organizations that can help them. If it's a school-based racial incident, then we talk about finding an educational advocate through one of the state organizations. So there's ways, and sometimes people just want a listening ear. They just want to know that their doctor actually asked them about this. No one's ever asked them, and they just are happy that you're even considering it. Let's talk about workforce development and professional education. So let me tell you, we have done a very poor job in training our medical students, residents, and fellows in implicit bias, racism, cultural respectiveness, and also the effect of racism on health. A horrible job. And we have not put this into the curriculum. In fact, there's a study that looked at the preclinical curricula for medical schools and found that race is often used as a biological construct when it isn't. So even on our licensing exams, on step 1, it may say, or I'm sorry, not step 1, but step 2, it'll say, 65-year-old, step 1, 65-year-old African-American man with chest pain. So like the fact that they put in African-American should not matter. This man is having chest pain, right? So why do we put those racial hints in our exam questions? Because it racializes the health problem rather than looking at the risk factor. Again, being Black is not a risk for bad health. Experiencing racism is the risk for bad health. Let's talk about community engagement. We can work with our communities in different ways to help eliminate disparities in education, healthcare, employment, and the environment. And we need to be doing more rigorous research that describes how racism plays a role in health determination and in training medical providers to be anti-racist in how they administer healthcare. So we have no nationwide systemic evaluation of racial bias for physicians and then changing that racial bias. And when you look at implicit bias training, there is no long-term outcomes for the vast majority of programs that have been described in the literature. So we really need some evidence-based, rigorous longitudinal interventions that are ongoing to reduce provider and racial bias in healthcare. We also need more national studies on the effect of racism on the health and behavior outcomes of people in issues of housing segregation, environmental justice. And please, in your research, do not conflate socioeconomic status with race. They are two different things. Not all Black people are poor and not all white people are affluent. They are two different constructs. So this is what I suggest we do as healthcare professionals. If you are colorblind, you need to do something about that. I'm going to encourage you to start building your racial empathy toward the lived experiences of millions of oppressed Americans. I want you to increase your own racial literacy and even understand your own racial awareness and identity and biases. Like I said, since February, we as medical providers have learned tons about this new disease called COVID-19, right? We have read till our eyes have bled. Everything coming out of New England Journal of Medicine and Pediatrics. Yet a lot of us in the audience today have never read one article on how racism affects health. So I'm going to encourage you to read. There's no national guidelines on training medical students, residents in the curriculum, and we need some. And please, you got to become comfortable being uncomfortable. Part of our growth, moving from being colorblind to a non-racist to an anti-racist, requires growing pains. It's going to be uncomfortable, but it'll be good in the end. And talk to patients about their lived experiences. It's really important. And start analyzing your own practice. We have electronic medical records now. So it's actually really easy to look at your own practice to see whether you've been administering equitable healthcare. Don't just assume it. We have to actually look at our own practices and research, constantly read and research about your own need to grow to become an anti-racist. Your colleagues of color cannot do your homework for you. This is what you have to do on your own. So these are some resources that may be helpful for you. Again, feel free to take a screenshot. I hope that this talk was helpful, and I appreciate you for listening.